Very good evening and welcome to all the faculty members who joined this platform and all the delegates and audience. It is really, it fills my heart with warmth to see the response to the webinars that we have had. And I never fail to repeat that it is a gift from COVID that we got, and we've continued because we get such an excellent response. So initially, we were doing a series of deep dives into selected topics in breast cancer, and for last 7, 8 months, we have started this series of webinars in the form of a master class, starting from the epidemiology of breast cancer, going through pathology, and now we have come to the topic of clinical presentation. When we were debating the structure of this webinar, so we realized that the traditional form that we have with a lecture followed by a panel discussion may not be really that interesting in this field. So we have chosen a different approach, which is based on different clinical presentations. And so we have a group of breast surgeons who will be presenting the cases and the faculty is going to discuss. Definitely, we cannot cover the complete spectrum of clinical presentations, but I feel that these interesting presentations will generate a lot of discussion. And with that, I will hand over to Dr. Vaishali Zamre to take it further.
Thank you, sir. So I extend the greetings once again to one and all. As Dr. Goel has rightly mentioned here, that we have actually chosen to discuss various clinical presentations of breast cancer here. And we have three young surgeons from very prestigious institutes across the country to be presenting three different case scenarios. And we have a great panel of experts. Before we begin, I would just like to reiterate that it's not going to be like a exam or viva kind of a thing, but we request the presenters to stick only to the clinical history and associated relevant history and clinical findings, and then subsequently the discussion will happen between the experts and the presenter for each case. And here actually we are going to present three clinical situations. One is Paget's disease, the other is pathological nipple discharge, and occult breast primary presenting as axillary lymphadenopathy. So to present the first case, I would invite Dr. Sneha Galande, who is a breast surgeon associated with Max Super Speciality Hospital, Vaishali. And the experts are Dr. Navneet Kaur ma'am, who is a Senior Director in Breast Cancer Surgery at Max Super Speciality Hospital, Noida. Ma'am has been a professor of surgery at GTB Hospital so far, and now recently she has moved into private practice. And she is also the President-elect of Association of Breast Surgeons of India. So welcome, Navneet ma'am. Then our next expert is Dr. Shalaka Joshi, who is a professor and the chief of breast cancer surgery, surgical oncologist at Tata Memorial Hospital, Mumbai. Dr. Shalaka, welcome. Dr. Kulranjan may not be joining us because his sister is unwell, or he may be joining late. Then we have Dr. Veenu Singla ma'am, who is a professor of radio diagnosis and imaging at PGI-MER Chandigarh. Welcome, Dr. Veenu ma'am. And we have Dr. Anila, who is a senior oncopathologist and a dear friend at RGCRC, Delhi. Dr. Anila, a very warm welcome to all of you. So, requesting Dr. Sneha to proceed.
Good evening, all delegates, faculty members, and experts. I thank the organizing committee for giving this opportunity to me for presenting case over here today. I'll just be sharing my PPT now. Is my presentation visible, ma'am?
Yes, ma'am.
So my topic of discussion today is Page's disease of breast, a rare but significant entity. So I am going to present a case of 60-year-old female who presented to us 2 years ago, and she had no comorbidities. She had two children, adequately breastfed. She presented with a non-healing ulcer over the right breast for past 6 months. The lesion initially started as a minor skin change over the nipple areola complex, and it gradually progressed over time. And she noticed there was erosion of the nipple, which eventually led to complete destruction of nipple architecture. And prior to presentation to us, she had consulted multiple dermatologists, and she was treated with topical ointments and antibiotics with no relief. The lesion kept on progressing. Eventually, it developed pain at the site of ulcer. And she also noticed spotting over the undergarments at night, but there was no clear history of active nipple discharge. This is when she presented to us. This was her clinical picture when she had presented to us. So as it is evident in this picture, there was an ulcerated lesion involving more than two-thirds of the nipple areola complex of the right breast, and nipple was completely eroded and replaced by an irregular erythematous raw area with well-defined margins, and there was surrounding hyperpigmentation and skin changes over the areola. There was no obvious pudgy-orange appearance seen in the surrounding breast skin, and left breast appeared normal. And on palpation, there was tenderness in the ulcerated area with induration at the base and the margins. Left breast was normal, bilateral axilla and supraclavicular foci were normal. So, given the history clinical examination, it was evident that we had to consider Paget disease in this patient because any eczema of nipple not responding to treatment, we have to think of Paget's disease until proven otherwise. So this could be the other differentials that we would have considered: eczema, psoriasis, fungal infection, seborrheic dermatitis, nipple adenoma, papillomatosis, Bowen's disease, and basal cell carcinoma. Now, prior to presentation to us, she had undergone a few investigation outside. So she had already undergone an MRI 4 months prior, which showed there was ill-defined thickening in the perioral region of the right breast. And also there was a small oval lesion measuring 7.5 to 5.2 millimeters, and it was a Biret's 3 lesion. She had also undergone a skin biopsy 2 months prior to presentation, and it had confirmed Paget's disease, acantholytic variant. So on presentation to us, we had done a mammogram for that patient, and it showed a well-defined ovoid opacity measuring 8.2 into 6.3 millimeters in the superolateral aspect of the right breast with no associated architectural distortion. There was early vascular calcification noted, and diffuse soft tissue thickening was noted in the retroareolar region with mild nipple retraction. It was given Biret's 0. So these are her mammogram images. So as it is evident in these images, the mammogram showed thickening of the nipple areola complex region, and
Dr.
also
Sneha, I think let us wait only till the examination findings and clinical history is presented so that the experts can take us through the various aspects of, how to manage and how to proceed with investigations.
okay, ma'am.
May I request Navneet Kaur ma'am and the other experts to please start discussing the case with Dr. Sneha.
Yeah. So thank you, Vaishali. Unfortunately, my video is not getting on. It is logged with my mobile, and if I try to adjust the settings, it will take a long time. So, but
Sure.
I hope I am audible, right?
You are,
So
ma'am.
that should work.
Yes.
So Sneha, you mentioned on examination you only could feel the induration behind the around the nipple areola complex. Was there any lump palpable
There was
that
no palpable lump, ma'am.
okay. The thickening which is being seen on imaging is not clinically appreciated.
Uh, Thickening, as such, it was evident on the MRI. Clinically, there was an ulcerated region with induration of that area, ma'am.
Okay, so I think you have very nicely given the details of the clinical presentation, but when you mention such a long-standing pages kind of a picture, it's very important to really make a very clear statement that there was no palpable or a palpable lump in the breast. That would immediately change our clinical impression from a in situ to a invasive disease,
Most
isn't it?
yes, ma'am.
Yeah. So patient has been under treatment for, and I think in this image at least there is a bulge in the axilla. So I don't know if it is axillary fat and a disproportionate kind of patient's orientation, or it was a finding on examination.
It was just
You had not much, in fact, discussed the axillary and lymphadenopathy in the axilla or elsewhere.
ma'am, I had mentioned there was no axillary and supraclavicular fossa were normal on examination.
But I think either this picture is rotated, but your picture shows there is a right axillary, either lipomatosis or a nodal mass. We don't know.
There was no nodal mass palpable, it was just fat, ma'am.
Axillary lipomatosis. Okay, okay. So what kind of biopsies had she undergone? Why were they not able to pick up till the time it has got so advanced?
Ma'am,
Dermatologists, did they take any biopsy? Because they are the ones who are good at taking punch biopsies.
yes, they had taken a biopsy for this patient and it had diagnosed Page's disease already. And it was acantholytic variant, but still she was treated with topical steroids and antibiotics for many months before presentation to us.
Maybe I missed the detail. So how long was the symptomatology happening there since she first noticed an lesion on the nipple and then till the time she reported to you? How much time had passed?
Ma'am. 6 months.
Just about 6 months. So it rapidly progressed, I would say, because pages grow very slowly. Either she noticed it late or she reported late. That is also possible because when they recall their findings, they may not be very accurate. And maybe it is an aggressive kind of. So did they kind of specify about anything beyond acantholytic, any immunohistochemistry or a grading given for DCIS kind of a picture?
No, ma'am. Only biopsy confirmed Page's disease with acantholytic variants. That's all they had mentioned.
Hi, I'm Dr. Anila. So they did not do any IHC to prove that it was indeed Paget's?
No.
Okay, no, because though it is very, it's easy. I mean, it's an easy diagnosis to make, but sometimes some other malignancies need to be ruled out, like a melanoma or something like that. So usually we do 1 or 2 IHC markers to confirm that it is indeed Paget's of the breast.
Agreed, ma'am.
Neela
This
ma'am, can you elaborate on what all
Yeah.
IHC markers would you do?
Yes, Dr. Vaishali. Actually, though this clinical picture was fitting into pages, the she's showing, but only thing is, we do some IHC marker like in the form of GATA3 or ER, PR to confirm that indeed they are Paget's cells and they are not melanoma cells or it's not a squamous cell carcinoma in situ. So melanoma, we will do HMB45 and rule out. And if it's a squamous cell carcinoma, usually we'll do a P40. So, but those cells, no, Paget cells, they are isolated and they can be very nicely highlighted by the use of GATA3 and ER. So this is what we usually do to confirm it is Paget's, because the DCIS component, which usually leads to Paget's, will be little far away and it will not be included in a biopsy site, in the biopsy from the skin. So usually we do IHC to confirm that it's
Yeah,
Paget's.
Hi,
thank
Dr.
you.
Vaishali. Good evening.
Ye-
I'm sorry I'm late. Shalaka here.
No worries, Dr.
Sorry. So
Shalaka.
from the
So,
picture that she showed, clinically this is pathognomonic of Paget's. Okay, and somebody missing it outside and or having a diagnosis and treating it with topical steroids is obviously wrong. So she should have been. So this is a clinical picture, and rather this must have begun as a small ulcer on the nipple, and then would have grown to involve the skin of the areola. But like Anila madam said, it's right that we would want to rule out a Bowen's disease if at all. But something that is so pathognomonic that begins with the areola, the nipple, and then spreads onto the areola. So I have once or twice before seen Bowen's disease, which is a in squamous intraepithelial squamous CA of the areola, but it generally doesn't involve nipple. Other
that's what
BCC,
actually I was going to ask Sneha. When we look at the clinical picture and what all specific things do we need to ask the patient, whether it is started from the nipple
nipple,
to,
yes.
differentiate it from other conditions and especially the, eczematoid conditions of the areola. So the most critical point here is that it involves the nipple. That is what actually clinches the clinical diagnosis, I would say. Of course, we need a biopsy.
Spread to the areola. Eczema usually starts in the areola, doesn't really extend to the
Right.
nipple.
Right.
Nipple.
Yeah.
And
Yes.
eczema will always have history of itching. So was there history of itching and
No itching.
no history of itching?
Scaling and ulceration it started with.
Right. And did she particularly say was there any bloodstained nipple discharge or some kind of ulceration on the nipple and then it spread, or that also points towards helps you get a diagnosis of Paget's?
Yes, eventually she did a report exuded from the ulcerated lesion, but not really bloodstained. It was yellowish and serous, she would say. It would just stain her the garments at night.
Right. So, and you say that on clinical examination there were no lymph nodes,
No lymph nodes, no palpable lump in the breast.
no underlying lump. So, what would be your first investigation then?
So we did a mammogram for her because she had already done an MRI and biopsy from outside.
No,
So
the first investigation is always a mammogram.
Yeah.
MRI is the second line. If you don't, because in 50% of these patients, you'll get microcalcifications, and in a few other percentages, you may get masses in the underlying breast parenchyma. So DCIS presents as microcalcifications, as we all know, and the lymph nodes, as far as the MLO view is concerned, they are not seen in the MLO view. So I don't expect lymphadenopathy, though the MLO view is very badly taken. It has hardly covered the axilla, only part of the pectoralis major is seen. Then on MRI, which very well brings out the lymph nodes, there are no lymph nodes reported. So we don't expect that there would be any lymphadenopathy. What we were seeing on the clinical images was an axillary fat pad, just a lipomatous overgrowth. So number one. Number two, on this mammogram, which is the first modality for, as I said, for Paget's disease, we see microcalcifications, which may be just subareolar, which may be in the breast parenchyma or breast masses. So in this case, we see a mass which is there in the upper outer quadrant of the right breast, which is pretty circumscribed on the MLO view. If I see, I can draw a pencil-like line around all the borders of the mass. So if we call it, as radiologists, we call it circumscribed. If we can draw this line around more than 75% of the mass, and this is seen better on the MLO view to call it circumscribed. So I will do an ultrasound after I look at it on the mammo, and if on ultrasound I see that the mass is parallel, the mass is oval or lobulated, and it has no posterior acoustic shadowing, so I will give it a BIRATS 3 and keep it on follow. But given the history of Paget's disease, it will again be, I think, an analysis that will again depend on the history and again whether it is a taller than wider mass. So directly calling it BIRATS 3 will be difficult. But if she has a functional imaging, either in the form of a contrast enhanced mammography or in the form of an MRI, then the enhancement characteristics of the mass will help us discern whether to keep it on follow-up by calling it a BIRATS 3 or whether to biopsy it by calling it as BIRATS 4 if it is showing washout kinetics. If it is showing persistent or plateau kinetics, I will keep it BIRATS 3 and follow it up. So what were the characteristics of this mass on MRI?
on MRI, it was just a small oval lesion and BIRATS 3 they had mentioned. Ma'am, the detailed report I did not
The
because
detailed
it's a
report
2 years
is
old
not-
case. In my records, I had just 2 to 3 lines mentioned about the MRI findings. I did not have the detailed report of it.
Did they elaborate on this ill-defined thickening in periareolar region of the right breast? Did they give any impression of that finding?
Ma'am, this is all that I have, ma'am.
Neha, can you show what Madam just described? Can you show that area which she's talking about in the upper outer quadrant with your cursor? Go back to
In
the
the
mammography image. Can you put that? Can you put a marker on that and show what she's describing, which I wanted you to describe?
Ma'am, I don't know how to put a marker on this actually.
Okay.
Just
Take your
you can
cursor,
arrow also. You can take your arrow. Yeah, the cursor there.
your laptop cursor.
Yes, this one.
See, it is a heterogeneously dense breast on mammogram that we call ACR grade C. and there is a mass very clearly seen in the upper outer quadrant of the, can you take your arrow there? Or your cursor there? And apart from it, there is definite thickening of the areola.
Areola complex.
Areola complex, yes.
And also retraction was noticed. Mild retraction.
Maybe that is due to ulceration.
Yeah.
So I think in the
Yeah.
background of a lesion in the nipple, which was so very evident, this second finding on mammogram has to be evaluated properly.
It has to be, but then on MRI, if it doesn't show any washout kinetics, as I said, if it doesn't show any enhancement for it to be called as BIRATS 4, we need to see the MR images, which sadly are not available. Actually,
Right.
I think we
Yeah.
can move on and just discuss what is available with us. I think that's the way to go forwards.
yeah.
Yeah. But I think
So with
in
this
the
mammo, the
situation,
question is,
yeah.
with this mammo, Sneha, what would be your next line? Would you want an MRI? Would you not want an MRI?
Ma'am, since it was already done a few months ago, we had not repeated
No,
any other.
let's say it was not
No,
done.
no.
Yes,
Let's
if
say it was
I
not
had
done.
done previously, I would have definitely wanted to do an MRI for this patient.
Why?
Ma'am, to look for if we are missing any other lesions and DCIS component or any calcifications or any other things, ma'am.
Calcifications are not seen on MRI. Calcification, the only modality that brings out calcifications best is mammogram. That is where mammogram is still the gold standard. This we all need to learn. At
Yeah, no,
MRI,
after the mammo. What I meant to ask was,
first,
after the mammo, when you don't see
yeah.
calcifications, you would want to do an MRI or not?
I think for all pages, if you're not palpating a lump and it is not showing on ultrasound and mammogram, you have to have an MRI to finally say that nothing is there in the breast and we can only deal with NSE.
Very right.
Yes,
Because
that is, I
MRI
think, a
Yes,
very
especially the heterogeneously
important
dense breast.
indication for breast MRI.
Yes, especially
Okay,
in
so
this
next,
kind of dense
go to the
breast.
next slide.
So with these available investigations and clinical findings, we had confirmed that this was a Paget's disease of right breast and there was no underlying evidence of malignancy on evaluation, and this was a clinically node negative and also radiologically node negative disease.
Did you ask them to get the biopsy blocks and review, or you would just trust what has been reported? Because somebody was just treating them with steroid creams despite a diagnosis.
We would have ideally repeated a veg biopsy to confirm the diagnosis, ma'am.
Or at least review the slides and see what all findings which are there, they corroborate, and maybe you could have asked for an ISC on the blocks that they were able to get you from the place where the biopsy was done. And my question to the other expert is, don't we do PR and HER2 new if we are thinking of Paget's, or it is only for DCIS? I thought all
No, we
DCIS
do a
would need.
complete IHC. We do a complete IHC.
Anila ma'am can chip in.
Yeah,
and
the
Anila
pathologist
ma'am.
can, yeah.
Yeah, we do all entire IHC, but just to differentiate Paget's from other conditions,
Other cancers.
GATA3, yeah, other cancers, GATA3 and ER is enough. But otherwise, we do ER, PR, and HER2, everything we do. Yeah, all the three markers. Yeah.
And they
May
generally
I
are HER2
just,
positive. And
yeah.
they generally, I think 50% would be HER2 positive.
Yeah, yeah.
Okay.
So what do
Dr.
you want to do,
Sneha, for the
Sneha?
sake of our audience, can you describe the correct way of obtaining a biopsy in this particular situation in case if there is no palpable lump and you have to prove your clinical suspicion? How will you describe the way you biopsy this particular patient?
I would want to take a wedge biopsy particularly, or a punch biopsy in this patient that would include the area of the ulcer as well as the normal skin from the margin of the lesion.
Okay.
And also depth of that lesion.
So a full thickness wedge biopsy with surrounding skin, normal skin, so that the pathologists are able to differentiate and correlate, right? Anila ma'am? Dr. Anila?
Yeah, yeah, I'm here.
So, is there any particular way you would want the biopsy to be sent to you in such situations? What will be your prerequisites?
Actually, I would like first of all, biopsy should have the ulcer area and a little bit of normal tissue with it, so that I can,
Yes.
make out. Because sometimes it's so ulcerated, I might not be able to make out whether any tumor cells are there. So a little bit of normal area and the ulcer is required. Yeah, that is
Yes.
required.
Correct. I think the audience must be now very clear how to obtain a biopsy.
And I
So
think we should also focus or discuss punch biopsy. It is far more easily done, right? Especially in the early stages when it is only confined to the nipple. You can just use a nice 4 to 6 gauge size punch biopsy needle and it just cuts a nice code through the nipple. You can take the normal part also as well as the involved part. And my question again to the pathology expert, which one do you prefer more, a punch biopsy specimen or a wedge biopsy for reporting pages? Or there is no preference as such?
I preferably would want a wedge biopsy.
Wedge biopsy. Yeah.
Yeah, yeah.
Okay,
Even
because
I would
dermatologists are
prefer
the
wedge
first to
biopsy.
see and they end up doing punch biopsies all the time. And normally with
Yeah,
that
yeah.
diagnosis, they send.
No, but I would prefer
uh,
a wedge biopsy. Yeah.
I think there could be some crush artifacts in punch, if I'm
No,
not
no.
wrong.
Punches.
Punch is a very
No.
smooth cut. It's a very round
Okay.
kind of a knife which just like holds like a pen and
Yeah.
you rotate and it cuts a very nice core through the
Yeah.
tissue
Yeah.
without any crush.
So you just rotate that, right?
Yeah, yeah. It's a kind of a
Yes.
pen.
Yes.
Yeah.
Ha ha ha. Yes, I've seen that. So please go ahead, the experts, with
What
the
next,
case.
Neha?
So,
Yeah.
What is
ma'am,
going
it's
to be your
discussion.
discussion?
So we decided.
We are not actually going to discuss the management part because we are going to have that at a later date. Here we are going to just clinically take the case only up to the workup, final workup till we are ready for management. We are not going to discuss management part.
So
Okay.
even with the workup, what was the final kind of extent of disease that was documented?
I will show that, ma'am. I'll show the final histopathology report. So this is our final histopathology report. So there was
No,
a
I think before you plan surgery, I think as Dr. Vishali said, we would be discussing management maybe in subsequent meetings. But with this kind of a presentation and with these reports, what is the extent of disease that you are able to clinically ascertain? That this involves only NSE, there is no involvement of breast tissue, or there is a need to maybe define how deep, because in the mammogram, I could see behind the NSE, there is an area of thickening.
yes. There was an area of thickening, but no well-defined lump was noticed in the retroareolar region on any of the investigations.
So do we take that rest of the breast was normal, or do we take it that we had some areas still to be identified or elaborated upon further, especially the one at the periphery? Because in such a situation, even a peripheral small lesion can't be ignored as being benign. So if you talk about diagnosis, what about the second lesion? Was it biopsied or FNA or any other investigation done, or we took it
Was
Barrett 3 and took it as benign?
It was a Barrett's 3 lesion on MRI also and on mammography also. So we had not addressed that lesion. It was out of
Okay.
our surgical field. So it was left for follow-up and observation.
But
Dr.
Mala, I would
Shalaka,
definitely
yeah.
appreciate this is kind of an MDT and we are discussing pros and cons. I would have wanted a core biopsy from the other lesion also, just to be absolutely sure if we are offering
Yes,
conservation.
Okay, ma'am.
correct.
I would excise
Uh,
it also during the surgery, because what happens even on follow-up, that these lesions can then create confusion.
hmm,
So if you have an B3 lesion, the only time we decide to excise a B3 lesion is if it's in the ipsilateral breast, because patients also have anxiety with respect to that.
yes,
So
correct.
sometimes just on table, if it's impalpable, then getting it localized by our radiologist prior to surgery, and then going ahead with your surgery, frozen section can help us what it is, the second lesion on table. Just do a separate incision and an small one and an excision biopsy. That does help.
Hi,
We would have
Dr.
done that.
Shilaka. Can I interrupt? I'm Dr. Sagu. And actually,
Yes.
this is my case. And when I had operated, Dr. Sneha was not
Okay.
with me. She's not
Hmm.
joined. And actually, I localized this lesion with J wire guided, and I had
Yeah.
done wide local excision of that lesion. It was far away. I have done a separate
Hmm.
risotto for the this
Primary,
primary
central quadrant.
and J
Okay.
wire localization and excision of that lesion, which came
Yeah.
out to be a fibroadenoma later on.
Yeah. We would have done that as well.
Yes,
Yeah.
Yeah.
same, same.
Thanks.
So, anything for the axilla?
So we had done sentinel lymph node biopsy for this patient, and sentinel biopsy was negative on frozen and on final histopath.
Can
Okay,
you
but
Would you?
omit that, or do you think you can observe the axilla in this case?
Given the clinical findings and the radiological findings that we had pre-hand before the surgery, we would have could have decided to not address axilla. But this patient was not compliant since the beginning because she was delaying treatment, and we knew that she was not going to follow up. Even 3 days ago, when I was calling her for the follow-up, she had not followed up in last 2 years also. So considering that, we had addressed sentinel lymph node biopsy in the same setting.
So I think my another suggestion on that would be discuss with the patient the possible treatment options. If she is somebody so unreliable who may not be following up, is non-compliant, don't know about radiation therapy, then discuss she should have a mastectomy rather than a breast conservation. So we have to discuss the options with the patient.
Yeah, all the
and see.
options. Sorry,
So
Dr. Namit. All the
no, it's
options were,
fine, man.
yeah, all the options were discussed with her. She was keen on conservation. We discussed her because of her non-compliant thing that we can just do mastectomy, and in that the other lesion can also be addressed, and you do not have to undergo these J wire and two surgeries at the same time. बट शी सेड दैट मुझे तो ब्रेस्ट बचाना ही बचाना है, इसलिए तो मैं सर्जन के पास नहीं आ रही थी। पहले का ट्रीटमेंट वो सिर्फ स्किन स्पेशलिस्ट से ले रही थी। 6-8
Yeah.
महीने शी वाज जस्ट गोइंग टू अ फिजिशियन और अ डर्मेटोलॉजिस्ट फॉर ट्रीटमेंट, शी वाज नॉट गोइंग टू अ सर्जन, and that is why she opted that. So on the same sitting we did sentinel lymph node biopsy also, 0/3 nodes, and so all the areas were addressed which we could, and later on we give radiation also to her.
Yeah, I think we have
Uh,
to. That is the shared decision making. Patients should know, and all their concerns should be addressed, right? At the same time, we have to tell them what is oncologically safe. Sagu, my just query is that could we have avoided sentinel node
Yes, of
if it was
course.
not a compliance thing?
Yes, we could have avoided sentinel lymph node biopsy because on mammo also definite microcalcification on areas were not seen, and even on MRI there were not any ill-defined areas which could have been suspicious. But I tell you, on biopsy there was DCIS. On final histopathology report there was a component of DCIS which was borderline, which was high grade. Sorry.
High grade DCIS.
Yes.
Okay.
Yes.
that's an indication. So,
Because she had a
my
very dense breast, and the retroareolar area was also not very nicely seen on mammogram also. And maybe we missed the microcalcification in that area, and she had high grade with comedonecrosis, high grade DCIS. Though the component was the size was not very big, but it was there.
Maybe
Okay.
like it was
can
just
I again
subaerial.
remind that we are probably not going to discuss the management part here. So let us please restrict ourselves to the complete workup till the patient is ready to be, treated. So let us discuss all the aspects of, pre-treatment workup. Dr. Vinu, please go ahead
I
with
was
your
just
question.
wanting to say, like DCIS stage 1 can be present just in the subareolar region. So normally, what I've read, like Paget's has 4 stages. First stage is just involving the nipple. Second is just involving the subareolar area, which has DCIS. Third stage involves the breast parenchyma, which has DCIS, and the fourth stage involves the breast parenchyma with an invasive ductal carcinoma. So this could be the stage which is having DCIS just under the nipple.
Absolutely.
Yeah.
Absolutely. It was same.
So,
Nice classification.
Yeah.
so Dr. Sneha, ma'am, is there any further question to Dr. Sneha regarding this particular case and the workup?
Dr. Vaishali, my one suggestion,
Yes.
we can call it discussion. These are all senior
Yes.
people. It's not a
Yes,
question
yes.
answer
No,
session.
no,
Is
no.
anything?
I'll rephrase any
Yeah,
further discussion point.
yeah. Expert comments that may come from people who are looking at
Correct.
specific areas.
Yes, yes.
So in the absence of any abnormal non-mass enhancement on MRI, or any abnormally enhancing mass that was seen on mammo, and absence of any lymph nodal enlargement on MRI, I think sentinel lymph node biopsy could have been avoided. This is my take on it, because on MRI is a very sensitive examination.
Dr. Venu, I just have a question. Is there a role of contrast enhanced mammogram in this case?
Sir, contrast enhanced mammogram, I have done, I think, the minimum work on contrast enhanced mammogram in the country. I have a lot of publications on contrast enhanced mammogram, and it is like it is my passion to research on contrast enhanced mammo. So in contrast enhanced mammo, the spatial resolution is less as compared to MRI. So given a case of Paget's disease, if I have to do a functional imaging for my patient, I'll choose an MRI over a contrast enhanced mammo, because the subtle non-mass enhancement in linear or focal or maybe small segmental distributions will be better shown by MR than contrast enhanced mammo. Contrast enhanced mammo sometimes is very difficult to interpret, and given the spatial resolutions, and only it gives you only 2D images, while in MRI you get multiplanar images. So MRI is better, and if available, and if the patient is not like the indication for contrast enhanced MRI can be if the patient is contrast enhanced mammo can be if the patient is claustrophobic. One, if the patient is unable to lie prone in the MR gantry. Two, then non-availability of MRI. Three, and of course, allergy to gadolinium. Four. These are the four indications for contrast enhanced mammo in this patient.
Okay, I agree with you. I just wanted to convey to the youngsters who
Yes,
are
sir.
listening
Yes,
to
sir.
it. Yes.
Yeah. Yeah. It is a beautiful examination, contrast enhanced mammo. It gives me the result within 5 to 7 minutes in the OPD. And I can, I am done with the functional component rather than for MR, wherein I have to slot the patient, which has long dates and waiting times, especially in tertiary care hospitals like ours. So, and the patient has to undergo that costly investigation in private setup otherwise. The CM is a very, very beautiful examination, but in Paget's disease, I will not do it.
Okay. Yes, I agree with you.
Yeah.
Is there any additional discussion point on this particular case, or else can I request Dr. Sneha to just sum up about the case and a little bit about the Paget's disease, what is so special about the way it presents, and the workup.
So
In
Paget's
maybe 2-3 minutes, because then subsequently we will move on to the next case.
Paget's disease being a very rare entity, may be missed sometimes. If it usually presents as a unilateral disease, not bilateral. If it's bilateral, we would consider eczema first. If it's a unilateral disease presenting with scaling and eventual ulceration and discharge from the wound, we should definitely work up that patient in considering it could be a Paget's disease. In the workup, the first investigation we would want to do is an mammogram that would give us idea about the nipple areola complex thickening and underlying lesions, DCIS, component calcification, all those findings. And after mammogram, if we don't have any definite findings, we should definitely proceed to an MRI for such patients to look for some lesions that we might miss on mammogram, especially in dense breast. So MRI would give us additional information. And to confirm the diagnosis, a pre-surgery full thickness wedge biopsy is must to determine the diagnosis, and we should also do immunohistochemistry panel on that specimen to differentiate it from the other differential diagnosis, and then we should plan the surgical management according to our findings.
Thank you, Dr. Sneha. Ma'am, is there anything?
One last line as a radiologist, ma'am, I would like to
Yes,
add to
please,
that
please.
for the youngsters who are listening, whenever you ask for an MRI in Paget's, please write dynamic contrast enhanced MRI. That is very important, because sometimes patients get non-contrast MRI done outside, which is of no use. That is my humble request. Yeah.
I think MRI of the breast should always be done contrast.
Yes, sir. Yes, sir.
Yes.
Non-contrast
Except in
MRI,
implant.
I
Except in
think
implants.
3D memo
Yes.
is as good as non-contrast MRI
Very
today.
right, sir. But unfortunately, in our country, all sort of practices available.
I agree.
Yeah.
I agree, Dr.
So
Veena.
only for implant rupture, or that is the only indication for a non-contrast MRI. That is one thing that for the youngsters I would like to tell. Thank
Absolutely,
you.
absolutely.
Thank you.
Right.
Yeah.
So thank you, Dr. Sneha, for your beautiful case presentation and a thorough, discussion. And thank you, Dr. Rajinder, to chip in. So let me now invite the next speaker, Dr. Virali. So she is a fellow in breast surgical oncology. She works with Dr. Navneet Kaur ma'am. She is working at Max Super Speciality Hospital, Noida, and she is going to present pathological nipple discharge. So again, we are going to have a very thorough and nice discussion on this clinical entity, which sometimes actually baffles us. So Dr. Virali, over to you now.
Virali, are you able to share your screen and unmute yourself?
Ma'am, not able to share
It must
my
be share screen at the bottom of your. So yeah, you can see the share this thing button.
Yes, ma'am.
So you
Share.
and keep your PPT open on your device so that when you share screen, it opens up directly. Yeah, we can
Yes,
see your
we can
PPT.
now
Please
see
go to
now.
the
Yeah, we
first
can see.
slide and start from there. You have to go to the first slide, right?
Yes. Thank you everyone for giving me this opportunity. Today I will be discussing the case of an 82-year-old female who presented with a complaint of spontaneous single duct blood-stained nipple discharge from her right breast for past 3 to 4 months. And the discharge was significant enough to stain her innerwear. She had no complaint of breast lump or pain, and there was no history of trauma, fever, or discharge from the contralateral breast. Regarding her obstetric history, she is a postmenopausal, more than 35 years, and has 2 children, and has no history of any hormone replacement therapy, and there is no significant family history of breast and gynecological malignancy. She is a
You
known
can go
case
to
of
the next
hypertension
slide.
and
Your slide has to move, Virali. You are on the first slide. Just go to the next slide. Yeah.
yeah, 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 ma'am. She is a known case of hypertension and osteoarthritis and was on medication for the same. And systemically, she had no complaint of cough, chest pain, and loss of appetite or weight and bone pain other than the knee joint pain. On her physical examination, a 1.5 by 1.5 centimeter firm irregular lump was palpable in the retroauroral and periauroral region at 2 o'clock position of the right breast. And the lump was non-tender, show restricted mobility, but not fixed to the overlying seam and chest wall. And on gentle compression on the lump, blood-stained discharge was elicited from her vehicle. Her left breast examination is within the normal range, and bilateral axillary examination shows no lymphadenopathy, and systemic examination is also within the normal range.
Before that, can you describe her ECOG for her age?
Sorry, ma'am.
Her performance status.
I mean, for her performance status and her comorbidities, anything other than this, medical conditions that she may have?
So yeah, I can answer that,
No,
Chadaka.
ma'am. There is
Virali was not
she
there
is
when
a
this
known case of
patient came
hypertension
in.
and arthritis. There is no other
No,
medical.
no. She was somebody who had difficulty in mobility, so she would very often come on a wheelchair. Other than that, she was able to do her routine activities herself. And I think she was from Lucknow. It was because she had a relative who was close to JP, so they brought her here for treatment.
So she was
Yeah,
ECOG 1, I would say.
yeah.
Okay.
Because Virali was not there when this patient came in, so she has not seen her. Okay.
There any particular point in your mind, Dr. Shalaka, before you wanted to discuss this regarding
Yes,
comorbidities? Yeah.
yes, because I would, before surgical planning, I would like to know her general condition and her comorbidities, because this is a case of bloodstained nipple discharge with a lump. So I know we are not discussing management, but
Yeah.
we are eventually going to operate on her with conservation or mastectomy, and to decide that a one-step procedure may be chosen by a patient who can't come to the hospital repeatedly.
Yeah.
So a one-step procedure can then be a mastectomy for that age. But then again, it will depend on a lot of the conditions. Right-sided breast lump, so I'm sure they can radiate. But these are all treatment-related issues. But the first question when I hear an 82-year-old is to understand her comorbidity index, so that's to plan the adjuvant better and to even plan the surgical management better.
Right,
So
absolutely.
Virali, can I
So,
ask you
yes.
what describes a discharge to be worrisome or pathological?
Ma'am, especially serious blood stain, single duct discharge, and associate with breast lump, which is a worrisome.
Without a lump, tell me 5 points that that make you suspect or make you describe pathological nipple discharge. 5 points.
Um, serous, serosanguinous, blood
Ha,
stain nipple
sanguinous,
discharge,
not serous, sanguinous. So blood stain, one
sanguinous,
point. Then
sanguinous discharge from single duct, unilateral
single duct.
breast,
Okay,
and
unilateral breast, correct.
breast. And,
And
age, age is most important, ma'am.
no, before that, with respect to the discharge, you said it in your presentation, but you must be able to sum it up.
Spontaneous, ma'am.
Spontaneous, perfect.
Spontaneous.
So unilateral, single duct, spontaneous, bloodstained, and one more thing, which also you said,
Um, sanguinous discharge, associated
profuse.
with lump
So,
and profuse.
copious or profuse.
Copious.
So these 5 signs, when they are there, we describe that as pathological nipple discharge that needs investigation.
And I think even a very clear watery discharge is also worrisome. So it's either a
Yes.
Yes,
watery clear
copious.
discharge or a blood stain. They both are to be worried about.
Yeah.
Correct.
So what is the first test you want to do for the 82-year-old?
Ma'am, she is a 82-year-old female, so I would like to do a first mammogram.
So I think what
Uh,
will be the first thing? My question to you is, what is your impression? She is a lady who has a blood stain discharge. She has a palpable lump, and beyond that, we haven't found anything positive. So what would be your clinical impression? And then with that, you will plan a battery of workup.
Ma'am, she's a 82-year-old age with blood stain nipple discharge with palpable lump. So my first differential diagnosis of malignancy.
What kind of malignancy? So you would think of a invasive breast cancer.
Yes,
Clinically,
ma'am.
she is an invasive breast cancer,
Invasive
isn't
breast
it?
cancer.
Yes.
Yes, ma'am.
So
Can it
now
be a
First test
papilloma?
again. Yes,
Can it
ma'am.
be a papilloma?
Papilloma can be a papilloma.
Yes, it can be.
So what are the
Yeah.
differentials? The first diagnosis probably would be, given her age and other things, invasive, but what are the other differentials that you will keep in mind, which can also give rise to similar presentation? Papilloma already mentioned.
Papilloma and
Suppose this was a tender lump. Lump was
yes,
tender, then would it have
that
changed
may be a
your
duct ectasia with associated with infections.
okay, somewhere down the list
The
that also should come, periductal mastitis or an
periductal
abscess can give
mastitis.
rise to this thing. Anything else you would like to think about?
What if there was no palpable lump and just bloodstained nipple discharge? Then what would you consider?
Ma'am, most
As
commonly
your
duct
first
ectasia.
diagnosis.
Yeah.
This is duct ectasia.
Pardon?
Duct ectasia, ma'am.
Still, I
Not
think
really.
the
If you
first
have, what is the
diagnosis should
most common
always,
cause of bloodstained nipple
yeah,
discharge?
Intraductal papilloma.
yeah.
Yes, a benign intraductal papilloma is the most common reason for bloodstained nipple discharge.
And
Ductal
ectasia will
ectasia
not have
peritoneum
that
asset is
red discharge, I think.
Yes.
Yes,
Yeah.
it's associated with
Yeah. The blood stained, I will always
greenish,
first consider papilloma, which is the
yes,
commonest cause.
yellowish.
yes.
So if there is no
So
palpable mass, I'll do a thorough ultrasound following a mammogram to look for small intraductal lesions, which sometimes are present just within the nipple or behind the nipple. So a thorough high resolution ultrasound is required using a linear or a hockey stick probe. So this is the way to go after a mammogram. If fortunately, like in this case, the culprit is picked up on mammogram, like in this case, you are seeing a mass, then you're fortunate enough you don't have to spend long time on the patient. Otherwise, a thorough ultrasound, especially of the subareolar region.
Dr. Venu,
yeah,
will you like to do a ultrasound first or a mammogram first?
Mammogram first.
mammogram.
Always a mammogram first.
Why not an ultrasound? Because on mammogram, when they compress, sometimes the secretions goes out, the dilated duct gets sort of collapsed. I may do an ultrasound and mammogram at the same sitting, but
In the same
ultrasound first and followed by mammogram.
No, sir. I will always do a mammogram first. That will serve as a roadmap to me. I will come to
Yeah, I
know.
know mammogram should be done
Yeah,
as a
yeah. In the
basic
same
procedure,
sitting,
but in
I
a
will do an
particular case
ultrasound.
like this, because
Yeah,
when they compress the mammogram, many times the secretions goes out, the ducts gets collapsed, and we may not get the correct picture on ultrasound if
doesn't
we are doing
happen,
on the
sir.
same sitting.
Yeah,
Because in my center, the mammogram and ultrasound is done by the same breast radiologist.
yeah.
They do on the same sitting, so and same day, virtually in most of the cases. So I may do a
I also do on the same day. Uh, the patient comes, is referred to me for evaluation for nipple discharge by my surgeon. So I do a mammogram, and following the same mammogram in the same sitting, I'll do an ultrasound. I prepare a comprehensive report of the mammogram and ultrasound, and then give it to my surgeon. That this is what I see on mammo, whether I see calcifications, asymmetry, or whether I see a DCIS component, or whether I see plasma cell mastitis like rod-like calcification. So I will give a comprehensive, because these two investigations will suffice in most of the cases. However, if the discharge is pathological and mammo and ultrasound are both unable to discern the cause of the mass, I will do an MRI in these patients. I will refer these for an MRI.
So I'm
Yeah.
sure Dr. Binu and other experts would agree with me that this is particular indication where even in adult, I mean, and even in 80 or beyond 50 postmenopausal women, we write bilateral mammogram plus ultrasound scan, especially with special attention to the nipple and retroareolar area. Isn't that? Shalaka, Dr. Navneet ma'am, I think this is what we usually write. Do you agree?
Yeah,
Yes, ma'am.
always,
Yes.
always. Mammography is always done bilateral unless there's only one breast. And my just a discussion point, when there's a palpable lump, isn't ultrasound more giving more information than a mammogram? And
So,
in that
so
case, will you change the sequence?
No, because still mammogram is the gold standard till date after 60 years of its invention, because it can pick up microcalcifications and tell me the intraductal extent of the disease, tell me the calcifications within the mass and associated with the mass. So mammogram will be, no, I will still not, and the contralateral breast, if it has a small cluster of calcifications, that again will be picked up by mammogram only. And I can then try to look for that cluster on ultrasound, whether I can biopsy that under ultrasound and not under stereotactic guidance, and save my patient again the huge amount of effort and the money she has to spend for stereotactic guided biopsy. I will try to always do a biopsy under ultrasound if I can for a patient.
Yeah, even we prefer a mammography first, and
Yes.
that can serve them as a roadmap. And
Yeah, correct.
maybe if at all, if the lady is less than 35 and then
Yeah,
has a
correct.
nipple discharge, you may consider an ultrasound first, if she's less than 35. And if you are really not suspecting, but even in that case, if it is pathological, like any of these five criterias are met with, we would also have a mammo and ultrasound. And in that case, the sequence is actually a matter of discussion. You would want both.
Very
Yes,
So
right.
we would
I
want
think
both.
sequence is just a matter of
Right.
discussion here. I feel
Agreed,
we
agreed.
require both.
Yes. We have Dr. Manjula also joining as a faculty, and Dr. Rajinder, both are there. They can also, I mean, I will request both of them to, participate in the discussion in case if you have any other important point to make here or even further. So please go ahead. Let us take this case forward.
And let's see the mammo images also.
Dr. Virali, yes.
Yes, her mammogram shows well circumscribed high density mass lesion in the retroareolar region measuring 1.3 into 1.2 centimeter and shows clear margin with no associated pleomorphic microcalcification and architectural distortion. There was a few axillary lymph node with intact fatty hilum.
Very
So
right.
what do you
As
think,
you
looking at
described.
this subareolar lesion, what is it likely to be? It looks quite rounded, isn't it? Well circumscribed,
Right.
smooth margins.
So as a radiologist, the moment I look at this patient and the clinical scenario, my first diagnosis would be papilloma always. I will think it will give me a mixed solid cystic mass on ultrasound. So, so this is the mindset with which I will perform the ultrasound.
I was also thinking of an intracystic papillary, something like an intracystic papillary lesion. It could be intracystic papillary DCIs also. That would also look something, basically a cystic lesion which has a rounded.
Basically all these intraductal lesions, encapsulated papillary carcinomas, intracystic papillary carcinomas, and even invasive papillary carcinomas can look like this on mammo. So the other diagnosis would be pathological or maybe on ultrasound if I can see and the solid component of the mass creeping into the adjacent parenchyma. I would think of an invasive papillary
Invasive.
carcinoma then.
Yeah.
Can a papilloma alone look like this, ma'am?
Yeah, papillomas can look like this. Yes. Yeah.
So this could also be a
Can
picture,
you
mammographic
It
picture
can
of a
be a
papilloma.
papilloma with atypia, without atypia, with DCIS, and as you said, encysted papillary carcinoma and solid papillary carcinoma. It can be either of these. All these diagnoses are pathological. These
Yeah, and
divisions.
then
we
would
would
you
In fact,
also
also
want to do a
there's whole range of presentation of papillary lesions. So from benign to DCIS to malignant. But we can look at this a very smooth rounded mass. So that is probably the finding on a mammogram that we get. It's not a speculated clinically very invasive looking kind of a thing. It looks more Barrett 4A kind of a picture. And then we can see the ultrasound scan of the patient, Virali.
Yes, ma'am. Her ultrasound shows lobulated cystic lesion containing thin septation and solid component in the retroaero region. And on Doppler imaging, the solid component within the cyst show internal vascularity. And based on these features, the lesion is categorized as a BIRAT 4A.
Yeah. So papillomas are always categorized as even if they're small. And if the patient is like asymptomatic, still we are, as per our guidelines, we are told to categorize them as Barrett's 4A. Because Barrett's 4A means only up to 10% of chances of malignancy. 0 to 10%. So always we cannot as let it go because in so many other ultrasounds also in asymptomatic scenarios these days we are picking up papillomas even if the patient doesn't have a discharge, evident discharge. Though you as surgeons might prefer, my surgeons also keep them on follow up if they are asymptomatic, but as radiologists we have to categorize as 4A lesions. So that is it.
Dr. Vinu, would you kind of comment on the wall thickening on one side? Will that be a
So
cause for Barrett?
yeah, this is a mixed solid. The top image is of the liver and gallbladder, which is showing cholelithiasis. The lower image is a linear probe, which is showing the breast mass, and it is showing a mixed solid cystic mass, and we can see that it is showing color on Doppler.
And enhancing distally. So that goes more in favor of a benign thing.
Enhancing distally, yeah. That is because it is a mixed solid and cystic mass. It is not a
Right,
completely
right.
solid mass, which is like a tightly packed carcinoma that will cause a posterior shadowing. While in this, we can see that there is that white area that you see distal to the mass as you go down the image.
Yeah,
That
yeah.
colors enhancement.
So I think it's the fluid component which is
It
adding
is
to the
the fluid
enhancement. Yeah.
component and maybe some loose cellular stroma of the solid component also. Solid component में भी color दिख रहा है इसमें ना, that white
Okay.
line उसमें जो दिख रही है ना color box के अंदर white line,
Yes.
that is a vessel traversing it classically.
So what picture will make it say Biret 4B or 4C?
तो अगर ये solid component मेरे को अब इसके अंदर आपको देखो, you can see a white line around it like this. If
Right.
this component goes into the parenchyma, then I will call
Right.
it 4B or C. I will then upgrade my BIRATs. That is
Okay.
it. Yeah.
So that is invasion. That would indicate invasion.
That is radiological invasion. Yeah.
Right.
Yeah.
And if it is actually now leading to a dilated duct, suppose, then what will you label it as?
BIRAT 4A only.
Biret 4A only.
Yeah. Intraductal papilloma. Then I will. Yeah.
All right.
So, Virali, what do you want? Do you want any more information from the radiologist, or are you happy now to plan treatment?
Ma'am, I would like to do a coronary biopsy first to confirm my
You
diagnosis
have to do a
because
coronary biopsy.
yes,
She's talking about radiological imaging. Any additional
Radiological
imaging?
also, but even I would definitely treat her with something rather than
As a
may or may not
radiologist,
do a coronary biopsy.
If your center has a vacuum assisted biopsy, which is it is always better to do a VAB in these cases than a
It's a
14-day
subareolar lesion,
coronary
ma'am?
biopsy,
It's
because
a subareolar lesion close to skin.
yeah, hydrodissection can be done. We can give a little saline between the lesion and the skin. About 5 cc or 10 cc of saline will be enough to dissect it away from the skin, and we can do a VAB for a better diagnosis to decrease the chances of upgrade. This is
So
easily
if VAB is only for confirming the diagnosis or with a therapeutic intent?
with the therapeutic intent, I think.
But then we wouldn't know the margin status.
Web can be a therapeutic management in this case, because if it
No, but if you are very sure it is
web
all
will be able
benign.
to take out almost 80 to 90% of this lesion. And if
But
it is
are
a
we
pure
sure it is completely
papilloma,
benign?
if it is a pure papilloma, I don't think we need anything else.
No, but is this a pure
We at
papilloma?
Vedanta have one of the largest experience in northern India of the web. We are doing very frequently, more than 1,000 cases we have done by now. And I think web is a very ideal thing for a case like this.
Let us ask the pathologist, Dr. Anila. Anila, ma'am.
Hi, Dr. Vaishali, I'm here.
So can you comment upon the sampling, especially when it comes to the papillary lesions? What kind of samples are adequate or appropriate for you to label them, whether they are benign or malignant? What would be the message to you, to the audience?
Yeah, actually, Dr. Vaishali and the audience, a true cut biopsy or even a VAB is adequate. But only thing is in papillary lesions, we need IHC to tell you whether it is a papilloma, papillary DCIS, or probably maybe some focus of invasion. But both these types of biopsies, these are adequate for making a diagnosis.
So that is for diagnosis.
Required.
So I think for a patient, when you have a suspicion, it is 4A. She is a very elderly patient having a very frank blood discharge. Taking it as benign and treating it with VAB as a therapeutic intent is, I think, taking too many chances. We will not have the full status, margin assessment, and other parameters. So this patient would need definitely an excision with a margin. So
yeah, I would prefer
VAB
that
probably,
too.
when you are not absolutely sure of a papilloma, probably is not a safe option. But if it is very benign, then obviously 2 centimeters, they can be easily.
Ma'am, VAB is not available everywhere.
Yeah,
so
right.
we cannot recommend biopsy and treatment because this can be easily excised even under local anesthesia.
Correct.
So along with microdocectomy, so the entire duct and that lump can be excised in toto, and the specimen can be then given to pathologist. It's a one-step investigation. If it's a DCIS or papilloma, doesn't require auxiliary staging. We are happy to even observe her. No radiation also required if it is a 82-year-old lady. So there is we
So I
wouldn't
think
send
the
her for a
caveat
VAB.
here, Shalaka, is that in papillary lesion, the frozen is very inaccurate or
Frozen
not
we
that
won't
sensitive.
do. We won't do
frozen
frozen.
So how
We
do we
can't do
know?
IHC.
So then we can't do one-step surgery. We just excise, then go in again if something is there.
I'm saying that we excise it with a little margin and we don't have to address the axilla if it's a papilloma or a papillary DCIS. So a
But we will
majority
be
of the
more
times,
sure when we do a biopsy and then go in. And we know that we have ruled out any, because of her advanced age. At age of 40, 80, I'm not expecting a benign papilloma developing in a duct. So I would keep my index of suspicion high for a malignancy. And a biopsy gives us more kind of a clear plan as to what we should be doing. How wide should we be going, and whether on
So
the same
you mean
sitting we can do a
coronal
sentinel.
biopsy?
Yes.
So I mean, we are discussing omission of sentinel node biopsy. This is a classic
Correct.
patient who can have
Yes, this is
omission
the
of
classic
sentinel node
patient.
biopsy.
Yeah, I'm sure
So
she fits into that. Omission of,
And
I mean,
omission
when
of radiation as well. She can
correct.
probably just have endocrine therapy pill in case she has DCIS or IDC instead. I mean, she may not even require much treatment. But I get your point. Getting a corneal biopsy to get like, prepare yourself, especially if she's younger, that would make definite sense if you can plan a better surgery later. Yes.
Yes. Anila ma'am, can you, Dr. Navneet has said that we won't do frozen section. So why would we not do frozen section
no,
in
we
case?
can do a frozen section, but with the
No, no.
limitation that
We
it will
just,
not be. Yeah.
so that's what
Yeah,
I want the
yeah,
audience
yeah.
to hear from the pathologist. Why is it not recommended to
Not
do
as
frozen
accurate.
section?
Yeah.
Yeah,
Why it is not
yes.
Yeah.
as accurate.
So,
So first of all, in frozen section, it is difficult for us to assess the first of all do IHC, because see on now in papillary lesions, all the papillary lesions, be it a papilloma or a papillary DCIS or a carcinoma, usually we tell you after we do our IHC for CK56, ER and SMA, etc. So
yes.
it's after confirmation by IHC we are able to tell you whether we are dealing with a benign or intermediate or a malignant lesion. Another thing is, at times in frozen section, it becomes very difficult for us to tell you if it is invasive or not. So
Yes.
that also is a caveat here. So telling, at the most, whenever we receive a breast lump, maximum we can commit is that it is a papillary neoplasm. But whether it is going to be benign or malignant, we cannot tell you at the time of frozen. For us to comment on invasion becomes very difficult at the time of frozen sections. So
Yeah. It
yeah,
is
if
the
Yes.
only
It's the
thing is which
IHC
can help is
diagnosis.
sometimes you want to know the margins. If they're adequate margins,
Yeah.
then margins we can comment upon. That is not an
Correct.
issue. But
Correct.
to differentiate between benign, intermediate, malignant, or DCIS and benign, it becomes very difficult on frozen. It cannot be made on frozen section. Yeah.
Correct. Correct.
So it is the morphology of the lesion because it is papillary with multiple fronts. So it is
Yeah.
not a very circumscribed margin which we can assess. That is why it is a lesser sensitivity compared to when we do for a conventional invasive ductal carcinoma.
Yeah, and there's one more thing. What happens sometimes the papillary lesions have undergone biopsy already, and when they come for frozen, so the biopsy tract at times entraps the papillary cores. So it starts looking invasive on frozen.
Yes.
So that
So
is
that's
also
was
one
another reason
caveat which
why
is there.
we prefer to remove it at toto rather than do a corneal biopsy upfront. I mean, often the pathologists, exactly the same point Dr. Tanuja Sheth keeps telling us that you will have false positive IDC invasion if you have done a
Yes.
corneal biopsy.
Yeah.
But I
So
think
that
core
happens.
cuts very cleanly and it's a coaxial two needles. The inner needle cuts and goes inside a sheath. So it should not be spilling cells into the track. True cut, we can say that because it is very manual and cutting may not be that sharp. So with a true cut kind of a biopsy, you may spill into the track. But with a core biopsy, automatic guns, I don't think that spillage should be there.
No, it's not about
That should
spillage,
be,
doctor. It's more
yeah.
that once the biopsy has been taken, and if there is some time lag between the true cut biopsy and the resection specimen later on, there is fibrosis which encroaches. So that fibrosis, it entraps the benign looking papillae and it starts looking invasive to us.
Okay, okay.
That is
So I
it's
think
not about the
true cut
spill.
has, yeah, true cut has that limitation.
Yeah.
So,
So next
anything?
slide. So we did do a biopsy.
Her core detail biopsy shows breast tissue core with lesion composed of epithelial cell arranged in branching papillary architecture, and there is no prominent nuclear atypia and mitosis. But crucially, the admixture of epithelial cell is noted. And the final impression of the core detail biopsy is papillary lesion of the breast.
So pathologist
that
has
is what,
again left it somewhere in the spectrum. On biopsy, it is not clear.
So that's
Yeah.
why a complete excision would be necessary.
Yeah. So that would be the next step. we have done our due diligence. Had it been an invasive papillary lesion, we would have been very clear in what to do. So at least on this, so I shared this case because till the very end, till the time we did a complete excision, and even then we had to do an IHC and some markers to be able to finally categorize, because papillary lesions have such wide kind of a spectrum of diagnosis, and they all kind of behave differently. So
Yes.
but since we are not discussing management, otherwise we could just share the entire this thing of the case. Interesting case.
Quickly, you can, Virali, you can share what you've done here, but we will not discuss that in detail because we have to discuss one more case.
Ma'am, after the final report of core needle biopsy, we advise the patient to underwent a wide local excision of the lump, and the specimen sent for the final histopathological report, and it shows a solid growth pattern and with papillary means composed of papillary front lined by epithelial cells and mild nuclear atypia. And the pathologist advised IHC marker, and her IHC marker shows ER positive, PR positive, HER2 negative, Ki67 less than 5%, and P63 shows retained myoepithelial layers at the periphery and mild decrease in intralesional area. And the final impression of the histopath report is papillary ductal carcinoma in situ. And after that, we put the patient on hormone therapy, letrozole 2.5 mg OD. And we advise bone mineral.
Correct.
That's fine. We can move ahead. We're not discussing
we can.
management.
Correct.
I'm very tempted to ask, but we are not.
We will have, I'm sure we'll have another session on management of, we had earlier management of papillary lesions, but we will have again in this present series. If we have no further points to discuss, are there any? Navneet ma'am, Anila ma'am, Shalaka, Dr. Manjula, do you have any additional point
I
to
would want the
discuss?
second opinion from the pathologist, because even I was trying to look up what actually distinguishes papillary DCIS from invasive or a benign spectrum. So I was not very clear as to why myoepithelial cells matter so much, whether they are present at the periphery, center, whatever. Maybe pathology expert can give some interesting inputs there.
Anila ma'am. Dr. Anila?
Hello? Yeah, I'm here.
Yes. Dr. Navneet has asked your inputs on papillary lesions and the role of IHC in differentiating.
Yeah. So what happens is, what I do is I usually put ER, CK56, P63, and SMA. Now, what happens when there is papillary DCIS or a papillary carcinoma? All my papillary cores, because they have monomorphic cells, they will light up with ER, and there will be no CK56 within the cores or adjacent to these epithelial cells. Only CK56 or P63 will be seen in the basal cell around the papilla. So that is how I kind of make the diagnosis. And ER will be 100% strong and diffused and in all the cells. P63 helps when I have to rule out an invasion. So if there is loss of P63 outside the papilla, the papillary cores, so if there is some focus outside, then my P63 or SMA helps. So that is how we differentiate.
Oh, so I understand now. The periphery was intact, retained, but in the core it was missing. So that is why probably they then categorize it DCIS.
Yes. In the core, P63 was missing and CK56 also a good stain. So that should be missing in the core. Yes.
Okay. Thank you.
All right. So here I would like to thank Dr. Virali and of course Navneet ma'am for sharing such great details of this case, and thank the experts as well to take the case thoroughly to a logistic conclusion. We'll move on and now invite Dr. Sai Lakshmi for the third case. She will be talking about, she'll be presenting a case of occult breast primary presenting as axillary mass. And Dr. Sai Lakshmi is a senior registrar working with Dr. Manjula Rao at Apollo Proton Cancer Center, Chennai. Uh, Dr. Sai Lakshmi, go ahead.
Good evening, everyone. I'll just share my screen.
Yes.
Okay. So our patient, she was a 38 year presented with complaints of left axillary swelling of 1 month duration. She was para 2, living 2, breastfed for 2 years, and first childbirth was at the age of 20 years. There is no history of oral contraceptive pill use. Regarding family history, one of her maternal aunts were diagnosed with breast carcinoma at the age of 48 years, and she was treated. There is no history of previous surgeries or breast biopsies.
Can you put it in presentation mode?
One
It's
moment.
yeah.
So on clinical examination, she was found to be obese, F cup with grade 3 ptosis. There was a 3.5 into 4 centimeter enlarged mass in the left axilla, which was freely mobile. Overlying skin and underlying muscle was found to be free. No palpable lesions in the left breast. The right breast, right axilla, and bilateral supraclavicular fossa were free. Head to toe examination was unremarkable. Systemic examination was also unremarkable, and there were no other palpable nodes elsewhere in the body. And she had actually presented to us with investigations done at an outside facility. So these were the investigations, an ultrasound breast which showed.
Wait, Dr. Sai,
Oh, sorry.
let us
Sorry.
get the experts actually, discuss the case with you and how to manage.
Okay.
So over to the experts now.
Right. So, I mean, I just have one suggestion. I prefer not to call anybody overweight or obese. I just mentioned the body mass index.
Yes, ma'am.
Patients don't like it in their
Yes.
notes to say
Mhm.
you're obese. It may be true, but
Yeah,
it's just
Yeah.
like fair to just write the BMI and mention the height and weight rather than call somebody obese.
Yes.
So,
correct.
clinically, what does it look like to you? Is this a suspicious lump or is this
It looked like a suspicious matted node in the axilla.
okay? And
You have
what in the rest of
written
the
it
body would you
as
like to invest
Sorry,
So what
examine?
ma'am?
all clinical diagnosis would come to your mind? You would straight away think of a malignancy. She
No,
is a
ma'am.
mobile lump in the axilla, nothing else palpable. So what
I
all
should think
possibilities should
about
you
other causes of generalized lymphadenopathy.
generalized? But she has only in
Yes.
the axilla.
Yes, ma'am. That's why we did did a head-to-toe examination and looked for other groups of lymph nodes as well. So that was ruled out. It could be other primaries as well. Could be
Other primary. So I think it is very uncommon. It's a very uncommon presentation of a malignancy, right? We have to think
yes,
of more common diagnosis.
especially in
uh,
India.
granulomatous disease, tuberculosis,
Yes.
other lymphoproliferative diseases.
Could it be a lymphoma, a mobile axillary? So one has to have a very open mind.
Yes. Yeah.
Yes.
She said
But
like the
she
rest
came
of
with
the
the
lymph node
reports
stations were
already.
normal.
Hmm.
Can I continue, ma'am?
Yeah,
So, what
my
other
only suggestion
malignancy
is,
sites?
yeah,
Sorry, ma'am.
Yes, ma'am, go ahead.
no, the only point I was wanting to make was that when you have axillary lymphadenopathy, occult thing is the last diagnosis that you would make clinically.
Yes, ma'am.
Yeah.
So first you have to rule out any other, especially infectious, inflammatory causes. Then obviously considering the age and the family history, of course, you have to think of malignancy also as one of the differentials, and then obviously, investigate accordingly. I'm sure Dr. Shalaka wanted to ask you something.
No, I just wanted to say what all drains to axilla.
Ma'am, breast most common. Other than that, even lung primaries, very rarely thyroid or ovarian can even drain to the axilla. GI,
And what is it called on the left side when you have such kind of notes? In another malignancy, like a GI, gastrointestinal tract malignancy, is there a name for it?
Like the left supraclavicular.
That is called what? Left supraclavicular is called what?
Not coming.
We have to go back to MBBS little bit.
Virchow's node.
Virchow's.
Virchow's.
Virchow's node. And what is the
Virchow's.
left axillary called?
Not sure.
No? Okay, so what all drains? I'm not talking about distant primaries. What all locally drains to axilla?
Head and neck. Melanomas can drain.
Head and neck melanomas or some other? What do we cause when we do axillary dissection? As a side effect, sequel.
Lymphedema.
Yeah, so what drains to the axillary lymph node?
The upper lymphatics.
Yes. I've had a patient who had a subungual melanoma of the little finger with an axillary nodal met, which was actually on biopsy melanoma. And it was only on thorough examination by one of my residents in the ward. They actually picked up that there is a small subungual melanoma, and then we had to do a ray amputation for the limb, for the finger, and then do the axillary dissection. So you could have malignancies from the upper extremity draining. Squamous cell carcinomas from the upper extremity can drain to axilla, having nodes. It could be skin malignancies. Squamous cell is a skin one.
Yes.
Even
Skin.
sarcomas, sometimes the rare varieties of sarcomas involving the upper extremity could drain to the axilla. And of course, you are going to do a diagnostic test, and the ball is going to be there in the pathologist's court, and they are going to tell you what it is, and then you are going to be wiser. But before that, as a part of your clinical examination, you must keep all this in mind. That yes, unknown primary in the axilla and the rest of the body being normal is very, very likely to be coming from the breast, because that's the main draining organ. But it could be another malignancy, non-breast malignancy coming from the upper extremity. I don't think head and neck thyroid mets, yes, they are seen. Even GI and other distant mets we see, but that could be a part of, a multimetastatic or distant metastatic process rather than a direct spread. So as a part of a direct first line spread, you could have an upper extremity malignancy of any kind that can have an axillary nodal drainage pattern.
Yes,
Absolutely. The skin and the subcutaneous areas also, Dr. Shalaka has pointed out. So we have to examine the back, the surrounding skin for any non-healing lesions. And as she has had the experience that there was a subungual melanoma also, so the extremities also should be thoroughly examined in addition to the other lymph node bearing areas.
Yes.
And I think a more detailed comment on what the lymph node mass felt like. The very the very texture. It was smooth, round, mobile, fixed, rubbery. All that features will help you.
Okay.
Yeah. So only saying it is freely mobile and large mass is not eliciting adequate information to categorize it clinically.
Yes, ma'am.
Yeah. Anyhow, I'm sure when you're making a slide, you only put the relevant points. It's not an exam that you are presenting a long case here. So that I understand. Yes.
Correct.
Let us
But
go
still, I
ahead
would say,
now.
putting T0 N2 MX there is a very quick take on the
Yes,
situation.
ma'am. It's because she had come in with reports from outside hospital. That's what I was trying to.
Okay.
That's why I didn't tell
That
the
was the
staging.
part of history that you had.
Yes, ma'am.
Okay. So let's hear that.
So this was our investigations done at an outside facility. There was an ultrasound breast report which showed multiple anechoic areas of variable sizes, measuring 10 mm to 11.7 mm in all quadrants of the left breast. No solid lesions were identified, and in the left axilla there was a single enlarged node which was 2.4 centimeters with thickened cortex. Core biopsy was also done from the left axillary node, which was suggestive of metastatic adenocarcinoma. And IHC showed a hormone receptor negative, HER2 positive, key 67, 12%. This
So
was a
ultrasound report shows multiple anechoic areas. If they are hypoechoic or isoechoic, I would not be much worried about. What is this anechoic area? I really don't. Maybe the radiologists comment
Normally, the
on
term
this.
anechoic areas is used for cysts. So she might be having a background of benign breast cyst fibrocystic change.
So
Because
hypo and
usually
anechoic are same.
no, they are very different. Hypo refers to usually malignant masses, and anechoic is without any internal echoes. So it is empty from inside. Anechoic without any
So I
echoes.
think malignancy we would generally hear heteroechoic. So they are not hypo.
Malignancies, no, malignancies are more often hypo than hetero. They're more often hypo than hetero.
Okay.
Yeah.
So
So,
since
so
she's young,
anechoic, multiple, look at every word, multiple anechoic areas of variable sizes in all quadrants. So in this, I will first of all think of a fibrocystic change. No solid lesion identified. That means these are all cysts. So,
right.
so for this, was a mammogram also done following the ultrasound?
Yes, ma'am. She presented to us with these reports, and at our center, we got a mammogram done. So this was a mammogram which showed an ACR type C parenchyma, heterogeneously dense breast. And there were microcalcifications noted in the lower outer quadrant of the left breast, which showed a linear group distribution with subtle underlying asymmetry. And in the axilla, there was an enlarged node with phase fatty hilum, which measured 4 into 3.3 centimeters in size.
So in that case, there is a very clearly identifiable lesion in the
Can
breast.
you just point out the microcalcifications in group?
Ma'am, there was a microcal
Okay.
here, a linear pattern.
All right. And on
Other
the
than that, there
MLO
are a
view?
few scattered microcalcification also, but
And on the MLO view, because it's very difficult to say on a laptop, we normally see on a mammo viewing station the bigger ones. Yeah, and no
So,
magnification.
Dr. Vinu, Dr. Manjula here. So, in reality, this case, the microcal is very difficult to see on the mammo also. It wasn't like your usual linear distribution of suspicious microcal, hardly one or two specks. And I mean, which is why as we move forward, you'll figure out why
The
we,
definition of
have done
a
whatever.
yes, ma'am. The definition of a grouped distribution is to have at least 5 specks of microcalcifications. So if I have less than 5 specks, I will not call it a grouped and I will not biopsy it. So 5 specks or more than 5 specks in a less than 2 centimeter area. That is the definition for group. Then
I'm not sure, but can you see
yeah, I
can
can
you
see.
see the
Yeah,
marking on the
I
screen?
can see. I can
Yes,
see.
okay.
Yeah.
Okay, that's the first time I've used that tool. But so when we saw the mammogram, this is what we thought he was referring to. We spoke to our radiologist as well. This is what he was actually pointing to. And I'll tell you, I think maybe I'll allow Dr. Sai to finish her presentation before before we discuss further.
Yes.
Sorry,
Yes,
I'm
I think
tapping
that
out.
will be. No, no,
This
no.
Sai, will you require any other investigation other
ma'am,
than a
yes,
mammo
yes, ma'am, it's a
to
dense
proceed?
breast.
And
And
would the pathologist want to run a larger IHC panel?
ma'am, we could ask for a larger IHC panel like GATA or even Soxten to, especially when the
Yeah, because a
hormone
lot of
receptors.
cancers are HER2 positive.
Yes.
Yes,
Even
ma'am.
stomach cancers are HER2 positive these days.
Pancreatic
So
cancers.
just HER2 positivity, ERPR negativity is not enough to get, and adenocarcinomas are all GI tract malignancies are adeno. So of course you need to look at the mammo and the microcal and probably do more tests on that. But I would want our pathologist would invariably more complete IHC panel, rule out ovarian, rule out all other anything else to do as a part of your workup of an unknown primary of axilla. It's called an Irish node, by the way. I should just complete what I
Yes,
started.
yes.
Irish node. When you have a left axillary node, which is an unknown primary, or which is like a metastasis from GI tract. So what more test would you want to overall stage the body completely?
Uh, Ma'am, for staging, I would first of all want an MRI, ma'am, because firstly it's a dense
No,
breast.
body staging. I'm not asking about the breast. You are still assuming this is a breast primary.
Okay.
I'm saying this is coming from ovary. How will you rule out that this is coming from where? It is an unknown primary. The classic investigation required for any unknown nodal mass, whether it is neck, groin, or axilla, as an isolated presentation, you need to do a test for the whole body.
Yes, ma'am. As per NCCN guidelines, it is CT, abdomen, pelvis, and thorax has been advised. But yes, ma'am.
Let's
Okay.
talk practical. I'm not really discussing NCCN at all here.
PET CT,
Practically, we
ma'am.
all do that.
PET
Let's
CT.
just discuss more practical stuff.
PET CT,
Thank you.
ma'am.
A
Would
PET CT
like
is
to
good
do.
enough. No, it'll give you everything. Anything else
Yes,
you could
ma'am.
do other than the PET CT?
Ma'am, for staging?
Mm-hmm. To understand where it is coming from, that's a panel or it's a battery for all unknown primaries I would like on day one in the OPD. A CA-125, a CA-19-9, and a
Yes, ma'am.
CA, the tumor marker panel
A120.
also goes
Markers.
Yes.
CA,
Yes.
also goes hand in hand with a PET CT. So tumor markers also go hand in hand in the investigations.
So,
And then if
can I
everything else is ruled
interrupt,
out and your
Dr. Shalaka?
pathologist,
Can I interrupt here?
yes, yes.
I would want you to tell me whether you would do a biopsy first or you would do whole body survey. I mean, in case if you are thinking of, other areas as primary, so would rather a biopsy not be done first and then take the case forward in case if it points to either a lymphoma or, some unknown primary malignancy. Will it be better to do biopsy first and
Madam,
then?
no, I think the biopsy report will come at least 5 to 6 days later. I would do everything on the first day because it's a 4 centimeter node. It anyway warrants metastatic workup because it's N2.
Right, right. Agreed,
But
agreed.
I
So
think
it serves both the
we are
purpose. It
still not
serves the
sure
purpose
it
of seeing
is, no, clinically we are still not sure it is a malignancy.
breast.
So FNAC of the
Yeah,
lymph node can
not
be a very
even,
simple test, and in some
yeah,
centers, everything gets done
yes,
on the same
that
day.
too.
What if it is tubercular? What if it is something
Hmm.
else? So all that will be unnecessary investigation,
Hmm.
isn't it?
But I'm
True,
sure
true, that
with
also.
such
But
a
I guess a
large node,
biopsy would.
biopsy will be preferred. Uh,
No, I think what madam is suggesting is to just begin with, to have
Yeah.
okay.
carcinoma seen on
So if you
FNAC,
think
then
it
go
is a
ahead with all the
malignancy, then go for
investigation.
a core biopsy. If it is a tuberculosis, you will very well diagnose on an FNAC or a sarcoidosis or some rare condition. So
Let us ask Dr.
even a
Anila
lymphoma,
what
at
is
least
her.
preliminarily you
Dr.
will have
Anila?
a lymphoma diagnosis, but it has to be further qualified by a total lymph node biopsy. Then even a core biopsy will not do enough.
But to
Dr.
be
Anila,
honest,
can we
I
have
So
feel
Dr.
your.
Vaishali, just 1 minute.
Yeah, please go ahead.
Just to complete now what you were whether regarding a PET CT, why I chose that is because a lymphoma requires PET CT for staging. If it's a breast, because of the size, it is requiring
Sure.
PET CT. So it kind of gives me in 1 or 2 days you will have the answer whether it is the only site and whether your intent is also what, whether it is a part of multiple nodes. And sarcoidosis or tuberculosis could have mediastinal nodes and other nodal sites as well. So it just gives you a pointer towards. I do a battery of tumor markers in
So I
almost all
think
cases.
PET CT is confusing in inflammatory conditions. That confuses the
Yeah.
diagnosis in patients in inflammatory conditions. So that would be, again, not just in the axilla, it may pick up nodes everywhere and give us a picture of a metastatic thing if we are thinking of our, malignancy. Then we would think that pulmonary and all nodes
so
are malignant.
No, but
So
PET
they are
with the
all
CT
okay, I would
component.
say.
Huh.
Sorry.
PET with the CT component, radiologists are able to tell us whether they are morphologically suspicious nodes or what.
But I
You
think
may
one of
need
the
additional
most
sampling.
yeah, the most important critic of PET CT has been is problem with the inflammatory lesions, especially in conditions where places where tuberculosis is endemic. That is why even though everybody uses it, but when it comes to saying that it is being used, most people refrain from committing on using for stage 2 and even earlier cancers the PET CT. So
For stage 2, I won't do.
Dr.
Only stage
Dr.
3
Vaishali, if I may come in.
Yes. Yes, please go ahead.
So just two things. One is in this particular case or any any other patient if with an axillary node like this, I would actually, or a mass, I would actually choose a core biopsy over an FNA whenever feasible, because very often it's a very operator dependent investigation, and very often we do come across false negatives, and many a times we don't get the option to choose between the radiologists also. That is one. The second thing is, I think we were just debating about PET CT and the confusion with inflammatory lesions. But the thing is, we would do a PET CT only for to add to the diagnosis. So that would come in only after we do a biopsy and we figure out, are we thinking of an inflammatory condition, a granulomatous condition, or are we thinking of a cancer? And only then would we actually go ahead and study this further and ask for a PET. So I think the discussion as to whether this could be an inflammatory versus this is maybe a moot point once we have a pathological diagnosis.
Think that was what I was actually thinking in those lines when I asked Dr. Shalaka about whether to do PET first versus a biopsy first. Let me ask Dr. Veenu, ma'am. Ma'am, I'm sure with your expert hands, you will be able to tell us about on ultrasound, especially whether the node is looking like granulomatous one or malignant. That will also help us to decide whether to go for FNAC or a core biopsy or the sequence of investigations.
Okay.
What do you say?
Given this case, I can see only one lymph node which is pretty enlarged, and I can see two more lymph nodes which are subcentimetric. And this lymph node does appear to have a thickened cortex, and on ultrasound, we have certain criteria to distinguish infectious or inflammatory nodes from metastatic nodes, like cortical blood flow, which is seen in metastatic lymph nodes, as opposed to maintained hilar blood flow, which is seen in infectious or tubercular lymph nodes. Then calcifications is the second point. Then the third point, like extranodal extension, may be there in metastatic lymph nodes. So given all these criteria, a lumpy, bumpy kind of a cortex, which we have that term in ultrasound, which has certain focal areas of cortical thickening where the tumors will sit as deposits. That will give you that ears to the cortex. So that will again point towards metastatic lymph node. And while biopsying these, I will always target these areas, of course, which have those nests of tumor cells. These are few criterias which will help distinguish. And in this case, if this cluster of calcification is considered to be the cause of a primary, is considered to be primary, then I'll straight away go in for first maybe a biopsy from the lymph node. And if it turns out to be, say, GATA positive, and if it suggests a primary from the breast, I'll do a stereotactic vacuum assisted biopsy from this clustered group of calcifications. If
Right.
it shows me a primary to be within the breast. Yeah.
Absolutely.
And Dr. Vaishali,
Absolutely.
you asked the
Yeah.
pathologist about the IHC panel, right? So
Yeah. Anila, ma'am.
And I think ask the pathologist about the FNAC versus core biopsy for a diagnosis of tuberculosis. Which one
Yes,
would
I
they
think,
recommend and depend on?
yeah. Anila, ma'am, are you there? Sunidhi, is Anila, ma'am, there?
No,
I,
ma'am. Maybe she's left, ma'am.
I don't
She
think she's
left.
there. I don't think she's
Okay.
there.
Okay.
our pathologists
So
do run
my take on FNAC is that we are discarding a very useful investigation just because it is uh, so cheaply available,
Ma'am,
right?
we are not discarding. What I would rather do is do FNAC as well as core needle biopsy both. Because
Yeah.
then
Because
if it is
FNA first, yeah.
uh,
FNAC first will give us good amount of information, which we further want to characterize, a core
quicker.
biopsy will be required. Even
Correct.
for say malignant, even in CA breast, when there is a malignant node, and if it is positive on FNAC, we take it as a positive. Then we don't insist on doing a core unless we want to do a targeted and clip it and do whatever. So
Right.
FNAC is one tool we should not discard, at least when we talk about resource stratified. No, I'm not saying you are doing it. In general, my point, take home point is that FNAC should still be used wherever it can provide useful information.
Very right.
And that's it.
Yeah. FNAC.
I
but
think
since this is
FNAC and, yeah, sorry,
Lot of
Dr.
FNAC.
Shalaka.
नहीं नहीं तुम्ही बोल. So I was just saying that since this is the only site and you don't want like a hemorrhagic necrotic center but FNAC report will come in 1 or 2 days, so a corneal biopsy will be eventually inevitable even for them to run the gene expert MJIT or whatever more
Correct.
they want on
Yeah, yeah.
tuberculosis.
Correct.
They will want a tissue.
And for
They will want.
lymphoproliferative disorders, also for doing a battery of immunohistochemistry markers, probably FNSC would just guide us how quickly do we need to evaluate the patient further in terms of the complete body staging
Body
with
work,
whole
yes.
body PET CT scan. So I think that would be I mean, many a times, if the the core needle biopsy comes out as ER/PR negative, that can happen, right? If it is a triple negative breast cancer, that can also happen. Then there is a whole different set of IHC markers to confirm whether it is coming from breast primary or somewhere else. So, unfortunately, Dr. Anila ma'am has, I think, left
So
or
what was the MRI picture of this
Yeah.
patient like?
Dr. Sai? Yeah.
Yes, ma'am. There was a non-mass enhancement in the lower outer quadrant of the left breast with segmental distribution and internal enhancement pattern of size 1.4 into 4.7 into 3.2 centimeters. And multiple enlarged nodes in the left axilla, largest measuring 3 into 2 centimeters with FAS fatty.
So what would you
Right.
do with this MRI now? What will be your next plan of action?
Ma'am, I
I mean, we
would
know.
definitely want a core biopsy from the lesion, image guided. And if the lesion is too small, I would because we did have a core biopsy done, which turned out to be benign breast tissue. So, and we suggested a vacuum assisted biopsy.
So when we looked at her first ultrasound report, it showed multiple anechoic areas.
Yes.
And now with MRI, what will be your next step?
I would do MR guided web.
I would ask them
we
to
know.
review. I
Excuse
would ask
me.
them to review the ultrasound with the mammographic finding in mind. Many a times
Yeah.
when they're not able to see it upfront, they can localize it afterwards
So
and
a
target that
focus second
area.
look ultrasound
Yeah,
is what is.
because many patients I have seen where the primary ultrasound scan did not pick up, but on review after MRI, they were able to see that lesion and biopsy. And under
Yeah,
USC
but they
guidance,
describe
biopsy
it.
is far more easy.
They're
This
describing
is
it
a
as
big
non-mass
sized.
enhancement. So non-mass
No, this is a
enhancement
big size lesion.
probably.
No,
Size non-mass
even then,
enhancement.
if they look
This is
back again,
non-mass
they may find
enhancement.
some findings.
Yeah,
And this is a fairly wide area. It's not small, little
it's
focus.
a
This
segmental
is size.
distribution.
Hare
Yeah,
Krishna.
it's not a focal or a linear to
It's
be like.
1.4 into 4.7, so it's a large area. Even if they do
Okay.
blindly in that area, maybe they will pick up the malignancy.
And using a 12 gauge needle to biopsy rather than a 14 gauge in such non-mass areas, I do a 12 gauge, which is freely easily available these days. Inside a core
Yeah.
biopsy, not a vacuum biopsy. So 12 gauge needle, I am a firm advocate. It acts as a bridge between your 14 gauge core biopsy and your 11 gauge VAP. So it is very good. So it is
Okay.
cost, it is very cost effective. And
Correct.
this is, as Dr. Navneet is saying, this is a wide area, and a second look ultrasound would definitely be of benefit to the patient and should be given a chance. Yeah.
And I was saying that because I had identical patient in a very large breast, it's not easy to palpate, especially the retroareolar area, which is more like a cylinder just behind the nipple areolar complex. So there was a lady who on FNAC of the axillary node was found to be metastatic. She was being seen by a gynecologist for a long time, being treated as eczema or some inflammatory kind of a thing because nipple areolar complex was quite turgid. Then MRI showed a lesion, and then a relook ultrasound, they could biopsy and diagnosis was confirmed.
So in this area, in this case, the pickup on ultrasound would again be good because it is in the anterior third of the breast. It's not a deep.
Yeah.
So on ultrasound, the radiologist will be easily picking up the superficial 1/3 masses. So that is it.
So
Right.
what
So
our
the
radiologists often end up telling us is, or what the discussion is, that if there is not a mass lesion and if it is not seen on ultrasound, if it is a non-mass enhancement, it will not be seen on ultrasound, and you will often require an MRI guided VAB, VAB just to improve the yield
Depends
of
on
the
the
procedure.
extent. Yeah, I understand. MRI guided VAB is expensive. It is time consuming, takes up the gantry time, needs to be scheduled, but like Dr. Navneet said, ultrasound guided procedure is there and then. It's just a 5-7 minutes procedure and definitely should be given a try.
Only
It
if it's
depends on
not
a
seen.
case to case. If it is not
Only if
seen,
it's not
yes.
seen.
Yeah, of course. Then you have no other option. If it is not seen
Yeah.
on ultrasound, then MR
Yeah.
guided is the way to go.
So we can't ignore these enemies, even if they're not seen on ultrasound and they're seen only on MRIs,
Very right.
especially in occult primaries, occult axillary nodes, we will
Yeah.
have to biopsy it one way or the other.
Yeah. Yeah.
Correct. But the facilities for performing MRI guided biopsies are sadly
Limited.
very rare and very infrequent. Yes,
Unfortunately, even in NCR, there are very few places who are doing.
correct.
Yeah, and
Right.
even we will put a clip there because she would begin with chemotherapy.
Yes.
So we would do an MR guided VAB and currently put a clip in there
Yeah.
and
Yeah.
then decide to take a call later
That's a
after
gold
chemo.
standard. We have to put a clip
Yes.
all the time.
Yeah.
Yeah. So they say that, I mean, correct me if I'm wrong, Dr. Vinu, that although the first ultrasound did not mention any, suspicious finding on the ultrasound, but nearly 60 to 70% of the patient, the second look ultrasound will give us some abnormality and which will allow us to perform a ultrasound guided biopsy easily.
Very right.
Is that correct?
Very right,
Yeah,
ma'am. Even more than 70%. It is
more
close
than
to, in
70%.
80% of patients in second look ultrasound, we are able to discern the and correlate it on ultrasound and then do an ultrasound
Yes,
guided biopsy itself.
correct, correct. Anything
What
further
was the
to?
core biopsy report like? What all
Ma'am,
information we had on core biopsy?
the report. It was
Benign breast
reported
tissue.
benign
It
breast
depends
tissue,
on the
nice.
actually the expertise of the sonologist. Is it a
Yes.
resident? Is it a fellow? Is it a consultant? Is it a junior consultant? Ultrasound is a very operator dependent investigation. So that is it.
So
And it
I'm
is
still
not
tempted to do
reproducible.
another biopsy
Yeah,
after this
yeah. Please get a good ultrasound and
or an MR guided VAB. I'm still hooked up on that.
So we had actually
But
suggested,
the whole problem is availability and the expertise of the
Availability.
ultrasound
Yeah,
and
yeah.
MR
I think
guided.
it's available with us now, and I'm very glad that our radiologists are able to do that.
Yes,
So I'm
yes.
able to say this
I think
freely, but I do
We
agree
are
that this.
we are also very lucky that we are having it
I
almost
think
for the last
besides the
10
availability, it
years
is the cost.
that
It is the
initially
cost
the
that
Jyoti was doing and now
it
Kulbir
is
is
the
doing.
cost that we
So
have
we
to
are
factor in,
having.
sir.
It's worth
Every
cost of
investigation.
pertuzumab. She's going to get pertuzumab, trastuzumab. It's less than one third of the cost of pertuzumab.
That's
she
Not
just
exactly
got
everybody,
when
not
patient
everybody
asked me
affords
what is the cost
pertuzumab.
of surgery, I said less than one chemotherapy.
Yeah,
So
even I
surgery
said
is the,
that.
but then we are avoiding surgery and we are escalating all systemic treatment. So that is our problem.
No,
There's
I
something
think
which
If we
can
don't
give
for
biopsy
the
us.
sake
this,
of
we
diagnosis,
will
I
end up in
think
a
in overall
mastectomy
treatment,
otherwise.
MRI guided biopsy is standard of care in selected cases.
Yeah.
And the cost, in the overall treatment cost, it is nothing.
And also, if we don't biopsy this later on, it completely disappears. We won't know whether to offer her
That's the
conservation
most
or
of
mastectomy.
that
So
is the most
No,
awkward.
biopsy definitely is required, and I'm sure it was could have
Whatever
been
may be
done
the
again.
method, whatever may be the method, we have to have a
Biopsy
tissue biopsy.
confirmation has to be there.
Yes.
Absolutely.
Yeah.
Dr. Manjula, you
So
wanted to
Manjula,
make
another
some.
biopsy, second one for her.
Yeah, so we actually, I had a feeling that the ultrasound guided biopsy would come negative, and I did ask the radiologist who's a consultant who did it to use a 12 gauge needle because on the mammo they were just that small,
Yes.
tiny microcal. So we had already told them in advance about a VAB, and then finally when this came as negative, considering the MRI, and also even though there was no lesion palpable. There was something that told me lower outer quadrant, even the feel, the so-called fibrocystic disease feel. I had a feeling that there definitely was some kind of DCIS. So just needed to prove it. So we did advise her. In fact, not an MR guided VAB. We don't have that facility in Chennai. Though we did mention it, and they are not the kind of patients who would go and get it. We thought we would attempt an ultrasound guided or a stereotactic guided VAB, whatever the radiologist wanted to do. But then they chose to not go ahead with it, and they said that let's go ahead with chemo, and after that if you want you can remove the breast and plan a reconstruction also. So we actually they said no to a biopsy because a VAB would come somewhere between 70 to 80,000. It would come up to within a lakh at least, which is why they decided to do that.
But Manjula, if I were to point out that she has a high BMI, her breast was F cup. So even the surgical planning would have,
Quadrantectomy
yeah, it would have been,
could remove the quadrant of enemy, and
yes.
that could also
Yeah,
suffice.
so that would have
Yes.
been useful
So
to go ahead with biopsy.
I 100%, we did
Hmm.
advise a biopsy, but then this was not the kind of patient who would. We did advise them that, but we
Yeah.
had a feeling that they wouldn't, and they chose not to go ahead with it. They're from Bangladesh,
Okay.
and they did not go ahead with it. And I did
Okay.
give them the option that, if it comes to that after chemo, we would, and they really want a conservation, we could try a quadrantectomy or even a mammoplasty for that, therapeutic mammoplasty for that matter, and just take out the entire quadrant because it was
Okay.
primarily the lower outer quadrant. Yes,
So
so
was the
that
PET
was the
CT,
plan initially.
PET scan
Was
done
the
here?
PET CT done finally?
Yes.
Yeah.
Yes, 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 we do a PET for
Yes.
all cases. T1
Okay.
also.
So,
I didn't mean
I
that.
can see, I
I'm
can see,
not in love
Dr.
with the PET scan or something.
No,
For
no, no. We
another
do
day.
it. We do it for all. I do a PET
Don't
scan
do
for
it.
all my cases, even T1. Dr. Shalaka.
Okay, let's have the
Don't do it.
discussion some other time, but let us focus
Yeah.
on this case first. Yeah, Dr. Sai, can we?
so ma'am, PET CT was done, which showed FTG event left level 1 and 2 axillary nodes, the largest node measuring 2.9 into 1.3 centimeters with an SUV of 15. Bilateral breast parenchyma was relatively dense and glandular, and there was no discernible FTG uptake or enhancing lesions. And there was no evidence of metabolic activity anywhere else in the body.
Okay, so PET
So
scan did not show
FDG did not pick up any activity in the
any
breast, nothing at
activity.
all.
No, no, nothing, ma'am, nothing at all.
Uptake.
And we have only MRI showing a lesion, which on biopsy is
Normal.
not coming positive.
Yes,
Okay,
ma'am.
interesting.
So I think more so the reason for that area of abnormality seen on MRI to be, sampled and proved
Second
to
time,
be,
yeah, a
yeah,
second biopsy would have been very
sick.
much required.
Yes. So although of course the patient did not agree to that, but I'm sure that was the way we should have,
100%.
evaluated her further.
Hmm.
Mm, any,
I
there
think
is, I'd
Vaishali,
say, yes.
we will have to wind it up.
So
Yes. Dr. Shalaka, anything?
no, I was just saying a very classic case of unknown primary axilla with something suspicious in the breast, and uh, it may not have an uptake on PET. I'm not that surprised because it could even be a DCIS with a focus of microinvasion,
Yes.
which is if HER2 positive could have such kind of a picture. And it's a
Hmm.
non-calcific DCIS which sometimes gets missed on mammographies and presents only as a non-mass enhancement on MRI. So this could
Correct.
still be treated with treated. Of course, the intent here
I
is going
think
to
in
be
the presence of
chemotherapy and then
such,
surgery.
yeah, in the presence of nodal, it has to be invasive. We can't think of a
Hmm.
DCIS only as
Yes.
there has to be invasive focus for
There has to
So
something
be
to.
invasive focus, yes. But
our
the other, ma'am,
surmise
the
was
other
this
reason
could
of
be.
a primary node in the axilla alone could be a tail primary, or can be an
Yeah,
Yeah.
correct.
breast tissue accessory. I recently had a
Yes.
lady with a accessory breast tissue having DCIS in the axilla,
Hmm.
which
Yes,
was
very
quite
much
surprising.
the point. Yes.
But I think this would be interesting actually, this point for a pathologist to come in because the biopsy showed metastatic disease in the axilla. They didn't call it a breast primary person. They didn't call it a lesion from an accessory breast or whatever. They said
Oh,
it's
at
a
times they say
there's
that
a
there are some
metastatic node.
It's
ectopic breast
completely
cells in the lymph
replaced.
nodes, and they may
Yeah.
become malignant, and that can give rise to a lesion in the axilla without anything in the breast. So, some ectopic breast tissue in the axillary lymph nodes. That is one of
Mm.
the kind of explanations for these
Yes.
pictures when there is only axillary nodal involvement.
Yes. Right. Right. Yes. Oh,
So, how
so
did she
I'm
respond
sure.
to chemo? What was her response to chemo? We can just
Uh,
interesting.
she did respond, ma'am. She received 6 cycles TCH, and post chemo, the nodal size had come down. It was a 1 centimeter vaguely palpable node in the left axilla.
But she
But
had an F
she,
cup with obesity, and we ended up with a nipple sparing mastectomy and what? Bilateral, the skin
She
reducing.
defaulted. She disappeared. We couldn't operate. That was the
okay,
tragedy.
This is the
okay.
plan. Oh, okay, okay.
No. Plan was, but when I did see her, nipple sparing mastectomy was out of the question unless we would have done the
Yeah,
vice
because
pattern
she's an N2
approach.
nodal
Right.
mass. I wouldn't
Yes,
choose a
yes.
nipple sparing mastectomy.
No, a
She could
vice
very well
pattern
have
approach
she
otherwise.
could very well have a therapeutic mammoplasty. What is the need
Correct.
of doing any nipple sparing?
Hmm.
She could have a therapeutic mammoplasty done and contralateral reduction to make her life easy. She's F size. I'm sure that's a difficult size to manage daily activities. So that would have maybe served her better.
No,
Yeah, we'll
100%. We gave her three options. Mastectomy, we gave her the option of mastectomy with recon, skin sparing, nipple sparing, or otherwise. And we did give her the option of a therapeutic mammoplasty. They chose to disappear. And we haven't been able to trace them and figure out what they actually went in for. These are, I wouldn't say, they cost sensitive patients. The kind who would go shop everywhere and so it
yeah.
was
So
it
we
was
Tell me her
tragic.
name, Manjula, later.
Later.
Shalaka
So
has
I
seen
think just
this
my
case.
last suggestion about the conversation here, we should have decision
Yes,
aids which help people make right choices. Given
correct.
everything in the background, the place where they're coming from, the resources they can manage, and the treatment plan which is going to cost. Then they don't disappear halfway with some investigations, treatment not completed. I think that kind of resource stratification has to come in our treatment planning. And cost is a big factor. I have worked in the public sector for 30 years, I know, and Sharaka also works in a semi kind of a public thing. Costs are huge, and people, land up in impoverishment. That all is happening because treatments have become so expensive. So we should be sensitive to that component also as much.
Oh, that's
And
very
I can
true. But
see,
there's also a cultural background to this where a certain section of population, their habit is to shop. So they'll go to various places, find out the
Yeah,
most
to those who can
the
afford,
cheapest
the
alternative.
kinds who can afford do the doctor shopping. They
Yes,
will
exactly,
check on all,
exactly,
yeah, and then make the
exactly.
choice they want to make.
Exactly.
So I
Though,
think
in my opinion, therapeutic mammoplasty would have been a beautiful option for her, considering with the contralateral symmetrization, considering the extent of process.
I'm sure we all do the documentation bit and explain all the options to the patient, right? And then obviously it is up to the patient whether they want to get the treatment done with us or anywhere else. So I'm sure we have had a wonderful discussion in all the three cases, and especially so with the last one. Would like to thank Dr. Sai Lakshmi. And if there are no further, pointers to discuss, I would hand over to Dr. Rajiv Agarwal sir for, concluding the
Yeah,
webinar.
thank you, Vaishali. I think in our master classes, this was our first experiment for case presentations. And I think it had been a wonderful session. There are three cases over a period of 2 hours. We had a very nice discussion with a very good faculty. I must appreciate Dr. Navneet Kaur, Dr. Shalaka, Dr. Anila, and Dr. Vinu. Of course, Kulranjan could not come. And of course, the young participation by presenters was a very nice. They have done a lot of good job. And I think we will continue in the future something like this. So without wasting much time, I think I thank to my all faculty, the presenters, the audience, and of course the event management company. So thank you very much. Good night, and we will
Yeah.
meet next maybe in 4 to 6 weeks time again. Thank you very much.
And thanks to Dr. Manjula and Dr. Rajinder. Dr. Manjula, despite being unwell, she agreed to join us. Thank you so much, Dr. Manjula.
Thank
And
you. Thank you. You're welcome.
with this, we look forward to having you all once again in very near future with our next webinar. We'll announce that very soon. So have a good night.